important in consideration during the procedure. Another is vital structures. During the ablation of vital structures such as nerve vessel, ideally, the vital structure should be within, not within 1 centimeter from the tip of the electrode. But sometimes the lesion is very close to the vital organs, so we can use the vital dissection technique. It's better to have a thermal needle to help us to avoid the damage. So the ablation time for each cycle about 12 minutes for osteoma, and the time is 60 minutes. 60 minutes usually is enough because the temperature is high. When we do osteoma, sometimes we need to turn off the cool tips. And we need to avoid the chairing, we need to do cauterization after procedure. Our experience, we have limited cases, 20 bone IFA cases. Most locations is in the pelvis, femur, and spine. The size variable depends. And we have 8 osteoma. One case recurred. This case is referred from other hospital. It recurred after surgery, so it's transferred to our hospital. When I finished IFA, it recurred about 1 year and go to surgery, it's stable. We have 11 bone metastases, 1 recurrent and go to surgery. 4 expired, but they expired not directly related to my procedure. We have 1 recurrent osteosarcoma. It's just for palliative expired. The complications are very rare. Only 1 case have a fracture after radiofrequency ablation. This man has lung CA with bone metastasis. It's a new uptake from the bone scan, a tiny uptake. It's the scapula. However, we cannot visualize on the CT scan. So we do MRI guided biopsy first and localization and change for IF needle. The same person has a plastic bone metastasis in the humerus. You can see the lesion here. Then we do IFA. After IFA, we can see the bone marrow edema and some soft tissue edema. Here demonstrates the pre-IFA, the uptake in the bone scan, and after IFA, it disappeared. This is a case with sarcoma with bone metastasis at the spine, and we first go to the vertebra with the tract to form the tract, and followed by IFA needle. After IFA, we do vertebroplasty to prevent its compression fracture. This is a young man has osteoma. You can see here with very evident prominent the bone marrow edema and the surrounding soft tissue edema. You can see here his nerve root has neuritis, so he suffers a pain. During the IFA, I go to the bone tumor through the Kelvin's triangle. So the target is here. But I use another IF needle here to do the water dissection, to inject some distilled water, try to prevent the nerve. So it's turned out to be okay, but it has still neuritis. It takes about 4 months for symptom relief. This is the same person. You can see the pre-procedure and after procedure. We do a diffusion weighted image. It can be helpful to help us to understand the regression, the bone marrow edema, and the bone lesion. So a brief summary, IFA is very effective in the safe procedure in managing bone tumor, especially effective in osteoma and variable in ablation of bone metastasis. Planning is very important, especially the pre-procedure. I think it is very essential. In many situations, I need to do water dissection to prevent neurovascular damage. MRI guidance is helpful. If available, it will be helpful for localization some bone tumors, especially for some cases you cannot see it on the CT scan. Thank you for your attention. Thank you.
Thank you so much, Dr. Wu.
It's my honor to be here to present my experience in cryoablation in kidney and adrenal gland. This is the short introduction of the physics of cryoablation. It's used Joule-Thomson effect. So in the needle, the argon gas and the helium gas is allowed to pass the needle, so it can cause a freezing zone surrounding the tip of the needle. So by repeat the freeze and thawing process, you can destruct the tumor. So it shows the process of cryoablation in agar gel, but it shows, I think the beauty of cryoablation is that you can actually put as many needles you want, and there are different size and shape of the ice ball you can choose. So basically you can shape the ice ball to any shape you want. So the advantage of cryoablation is less painful as compared to thermal injury. And the ice ball is very clearly demonstrated by CT or MR, and it has less damage to the collecting system. But there are some disadvantages. It is more time consuming. One cycle needs around half an hour to finish, and it also increased chance of bleeding as compared to heat. So renal tumor is the main stage of the cryoablation. It's gaining more and more popularity as compared to IFA. Why is that? This is an early animal study. It shows that on the right side, this is the collecting system after radiofrequency ablation. You can see the sloughing of the epithelium, the urothelium. And on the left-hand side is the cryoablation, and the urothelium is intact. So cryo did less injury to the collecting system. So that's why it has less complication, urological complications. And the current indication of cryoablation of renal tumor include non-surgical candidates, bilateral disease, and previous surgery with recurrence. But actually, it varies among different centers. It's decided by insurance reimbursement and availability of the facility, of the technique, and the surgeon's aggressiveness. In Taiwan, our national insurance system, they make reimbursement for renal tumor which cannot be operated, and but not other organs. And because the urological surgeon in my hospital is very aggressive, so basically I can only have a patient who is either too old or too sick. And so I think if the partial nephrectomy is not available in your, or the surgeon is not so familiar with the partial nephrectomy, I think you have very good chance to develop the cryoablation for renal tumor. And this is the typical case I got. This is an 88-year-old male. He incidentally found to have a renal tumor on the left kidney. So our pre-procedure preparation is quite routine, and we use IV sedation during the procedure. It is not because of pain, it's mainly because it's time consuming and the patient is difficult to hold the position still. So I usually let them sleep. And biopsy is an issue because I usually recommend biopsy to confirm the pathology first and then arrange another session of cryoablation. But some patients, especially those who have coagulopathy, they prefer to do the biopsy and the cryoablation in the same section. So usually I put the probes all in the tumor, and then the last step I do biopsy. Otherwise, the hemorrhage might obscure the ablation field. And monitoring is important for cryoablation, and because it is the eyeball is very clearly shown, and it's very sharp margin during the procedure. And I usually use reconstruction technique during the procedure and monitor every 5 minutes. And this is the 24-hour follow-up. In our early cases, I follow them in the next day, and you can see the residual enhancement of the tumor. But in 1 month follow-up, the enhancement is gone, and the clear show the ablation area. The enhancement actually can persist up to usually up to 3 months during the follow-up image. And there are some techniques we can use during the procedure. For those tumors completely embedded in renal parenchyma, we can use contrast administration during the procedure. And hydrodissection is quite commonly used, especially for bowel loops. And for those in the retroperitoneum, since hydrodissection is not usually effective in the retroperitoneum, so I usually put a balloon to displace the ureter and other vital organs. And for those close to ureter, I always ask the urologist to put double J ureter stent in advance. And for tumor, which is very central, I do pyeloperfusion, but I found this is usually not necessary because cryoablation is actually very safe for centrally located tumor. And this is the case. This tumor is just close to the ureter. This is the ureter stent in the ureter, the white spot, and it is just the tumor just contact the ureter. So I put a balloon to displace the ureter, so I can ablate the tumor safely. Complication, according to the meta-analysis, the overall complication rate is around 20%, but bleeding is the most common complication. In my experience, it can be delayed. My patient is asked to absolute bed rest for 4 hours after the procedure, and injury to colon and nerve and ureter is also complications and infection. And also, sometimes if the skin is not well protected, we have to use oral normal saline to protect the skin during the procedure. If it's not protected, it can get frozen bite. And our outcome, this is from the literature. The percutaneous cryoablation can provide local control rate of between 88 to 99%. Now we have in 30 cases, our experience showed that technical success is very high, it's 100%, and local control rate is 90%. We have 3 recurrence. And as compared to RFA, it's from the literature, cryoablation has improved local control rate, and there's a new in 2012 in this meta-analysis of case series study, they showed no statistical significantly difference between the 2 techniques. But obviously, cryoablation has the advantage of less painful as compared to IFA. In terms of renal function change, in our experience and from the literature, cryoablation, it is of course more effective than robotic assisted partial nephrectomy in preserving renal function. And in our experience, the renal function preservation is very good. Also, about 2/3 of our patients had chronic renal insufficiency. before the procedure, the percentage change of EGFR has no significant change. We have some cases of single kidney and some have very poor renal function, but none of our cases required hemodialysis afterwards. So I think the renal function preservation is very good. And next I will talk a few our limited experience in adrenal tumor. The indication for adrenal tumor ablation include benign functioning tumor and malignant tumor, mostly metastases from other primary malignancies. The current indication for cryolation of adrenal tumor include non-surgical candidates, difficult anatomical location for surgeon to approach, and also previous surgery with possible adhesion and recurrence. And this is a case who is a 41-year-old female. She has hypertension, poor response to medication, and she had an adenoma, a typical adenoma here. But because the adenoma is very high position, almost totally embedded in liver, so the urologists, they don't want to touch it, because if they want to remove it, they have to mobilize the whole liver. So they asked me to ablate it. And this is during the ablation. This is the localization, and we put the needle in and make a small ice ball here. And we do the first freeze, and then change position and do the second freeze. You can see the tumor is well covered by the ice ball. This is the vital sign during the procedure, and you can see very interesting that her baseline BP is almost systemic, is almost 200, and this is during the first freezing. And afterward, in the first thaw, you can see the blood pressure jump up a little bit, and then it goes down again. And during the second freeze, the blood pressure jump up even higher. And then after the procedure, it go back to about 150. And this is in the recovery room. You can find her blood pressure go back to around go down significantly, and her aldosterone level also decreased. So for ablation of adrenal lesion, the hypertension crisis should be aware of. It usually happen during or immediately post-ablation. It has been reported in both IFA and cryo. And premedication with alpha blocker is recommended for functioning the tumor ablation. And for adrenal tumor ablation, there are some anatomical considerations. I'll just show the case here. This is HCC with adrenal gland metastasis. The tumor is here in the left side. And during ablation, you can see the ice ball cover the adrenal tumor, but also the diaphragm crus is also covered. And because it's very near to pleura, so immediately after treatment, there's a pneumothorax. And in the follow-up CT, you can see the enhancement is gone, but also the diaphragm crus is also very swollen. But the patient actually, he did not feel much pain. And complications, as we just mentioned, are this. I just want to mention that adrenal biochemical insufficiency should be considered if more than 90% of adrenal tissue is rendered non-functioning. So if the patient has another adrenectomy for another site, you have to be careful about the complication. Thanks for your attention.
Good afternoon, Chairman and ladies and gentlemen. It's my great honor to be here to show some experience of the cryosurgery for pancreas tumor. So this is that has shown the pancreas cancer still the main problem for us to be. Because when a diagnosis, more than 80% cannot be operated. So this is a big problem for we could do something. So the question is pancreatic cancer with ablation possibility. Yes, seldom of this treatment has been used for pancreas. But in the beginning, I think one of the things for prostate cancer, why cryosurgery has used so popular? Because ablation worry about the urine duct, the rectum, bladder. The pancreas cancer also the same problem. Do you know bile duct, and this is a problem. Ablation has been done by many doctors. This is Professor Koppen from Austria. Before they do open and cryosurgery, they do many basic research and some animal. Before they use the liquid freezing. This is directly freezing the tumor, pancreas tumor like this. And the result for the patient is okay, it's good, no such serious side effect, and good local control. This is the professor from US. He published his experience also in open cryoablation for no serious problem. Another also is from China. They have these two. The cases is about 68 of the patients when doing open cryosurgery. Generally, no serious problem from before their research. So also we do some animal experiment. So after freezing, this is the pig's necrosis of pancreas. The margin is clear. Also we do the freezing near the head pancreas cryoablation. Generally it's safe if you. So for continuous cryoablation for pancreas, it is possible because many patients have to do operation or they refuse that. This is a big problem. So we also do this. We publish a paper. There is 4 points we think we can try. If the tumor in the body and the tail, in the body we can directly, and in the head. So from this panel we must through one is gastric. Another way, sometimes you must through the left of the liver. Some you can directly inside. But in the tail of the pancreas, it's easy because you can the stolo route.